Hello and welcome to today's COVID-19 update webinar. My name is Bev Bromfield and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with our speakers, dermatologist Dr. Gelfand and rheumatologist Dr. Christopher Ritchlin. For over 50 years, the National Psoriasis Foundation has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan on July 1, 2019. With a continued focus on a life free of psoriatic disease and its burden, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals: to lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research initiatives. To date, NPF has funded over $24 million in grants and fellowships. This includes $3.7 million in the grant and fellowship funding announced this summer. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the Foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee. We were urged to define prevention to better guide the proposal development and how it's expanded to disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you, as a patient, can be involved in. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the U.S. The registry collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to patients, and explore the history of the disease. There are currently more than 11,915 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. If you're not sure, ask. But if they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or good-take psoriasis, and be a candidate for office or home phototherapy. There's no washout of topical, oral, or biologic medications, and the study is designed to easily incorporate into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you, as a patient, answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research, conducted each fall, provides insight into the experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we would appreciate you sharing your experience with us. And finally, to achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis, Walk or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about what is COVID-19 and the purpose of the NPF COVID-19 Task Force, basic content of the 22 guidance statements and what they mean to you as a patient regarding risks and treatment options, resources to help stay informed about managing psoriasis and psoriatic arthritis during the COVID-19 pandemic. Now I'd like to introduce you to our speakers, 2 world-renowned experts in their fields, dermatologist Dr. Joel Gelfand and rheumatologist Dr. Christopher Ritchlin, who co-chair the NPF COVID-19 Task Force. Dr. Gelfand is a professor and vice chair of dermatology, as well as director of the Psoriasis and Phototherapy Treatment Center at Penn Medicine, University of Pennsylvania in Philadelphia. He is also the vice chair of clinical research and medical director of the Dermatology Clinical Studies Unit, where he also leads the LIGHT study, which I mentioned earlier, which is the real-world study comparing the effectiveness of home versus office-based phototherapy. And Dr. Christopher Ritchlin is a professor of medicine and chief of the Department of Medicine, Allergy, Immunology, and Rheumatology at the University of Rochester Medical Center in Rochester, New York. He is also the co-director of the Psoriasis Center and the director of the Clinical Immunology Research Unit, which is currently investigating pathologic bone reabsorption and new bone formation in inflammatory arthritis, along with the efficacy of different treatments for such diseases, which includes psoriatic arthritis. It is my honor to welcome Dr. Joel Gelfand and Dr. Christopher Ritchlin, who will present a COVID-19 update. Please welcome Dr. Gelfand and Dr. Ritchlin. And these are the disclosures for Dr. Gelfand, also disclosures for Dr. Ritchlin. And now we'll welcome Dr. Gelfand.
Okay, thank you, Bev, for that introduction and for all the hard work you've done behind the scenes to bring the webinar together for our community. It's a real privilege for me and my colleague Chris to work together and to be here with everyone this evening. We're going to start off by discussing what is COVID-19. And there's some terminology that as physicians and scientists we sort of use to be pretty specific about things. SARS-CoV-2 is the actual virus that causes COVID-19 illness. And what it is a single RNA-stranded virus that has a spike protein on its surface that binds the ACE2 receptor, which is present on epithelial cells and many other types of cells in the body. And this is how it enters the body and then causes infection. Our nasal mucosa, for example, is lined with ACE2 receptors, and that's why it's not uncommon for patients who have this infection and develop the COVID-19 illness to have things such as difficulty with taste or smell, because those are the cells that get infected early on in the course of this illness. The common symptoms include fever, cough, fatigue, shortness of breath or breathing difficulties, and loss of smell and taste, as I just mentioned. Although it primarily is a respiratory tract infection, it can be more of a systemic infection, infecting the heart, the central nervous system, the GI tract, and the skin, as well as promoting things like clotting and thrombosis that could lead to things like heart attacks and stroke. So who is at risk for having bad outcomes from COVID-19 illness? Well, first, you've probably heard about the risk of getting infected. And we know that infections can occur at any age, but most commonly occurs in young adults, people, adolescents, and older who are most susceptible to becoming infected with the virus. This is because younger individuals tend to have less of the receptor in their respiratory lining and therefore are a little less prone to getting infected. However, they're certainly potentially vulnerable to getting infected and having issues from the virus. Those who are at highest risk for having bad outcomes from the illness of COVID-19 are those who are older, particularly people older than 50 or 60 or 70, being obese, type 2 diabetes, having cardiovascular or kidney disease, or having other immune-based abnormalities, including generalized immunosuppression, usually the type of immunosuppression we're talking about with things like a transplant, a kidney transplant, for example, not necessarily the type of immune modulation we use to manage psoriatic disease. Now, the concerns here, of course, is that many of the comorbidities I brought up here, we know are more common in people with psoriasis, particularly as the disease gets more severe. So cardiovascular disease, kidney disease, diabetes, obesity are all things that tend to increase with severity of psoriasis. So in March of 2020, the National Psoriasis Foundation released medical board COVID-19 recommendations for patients with psoriatic disease. This is very early on when the pandemic was just taking hold in the United States. And then recognizing the need for a broader level of expertise and perspectives, as well as a systematic and strategic way of dealing with the unfolding pandemic, in May of 2020, the National Psoriasis Foundation formed the COVID-19 Task Force. And this includes experts from the National Psoriasis Foundation medical and scientific advisory committees, as well as experts in dermatology, rheumatology, infectious diseases, critical care, epidemiology, and immunology. And many of the members on our committee have frontline experience dealing with a surge of patients with COVID-19 illness. Our purpose is to closely monitor the evolving data and science advances to identify critical needs and respond to questions from the psoriasis and psoriatic arthritis community relevant to COVID-19. And our goal is to address both the short, mid, and long-term needs of our community. On August 20th, we released our first set of guidance statements, and they're really titled version 1. It's really the beginning of the process of providing guidance to the community as our knowledge expands. And we use something called the Delphi process, which is widely used in the field of medicine to achieve consensus on recommendations. So it's sort of a robust way of ensuring that all the different viewpoints are heard, and ultimately we're able to give some objective evidence of our level of agreement for the recommendations we give to the community or potential level of disagreement. Okay, so let's talk about the guidance statements. So currently there are 22 guidance statements or recommendations which are intended to aid in the management of patients with psoriatic disease during the COVID-19 pandemic. Our goal is really to help promote optimal care and outcomes for those with psoriasis and psoriatic arthritis. A paper summarizing our methods, the data behind our recommendations, and of course the recommendations as well. And that was accepted by the Journal of the American Academy of Dermatology, what we call the JAD, early September. And this is sort of the premier journal in dermatology. It's the most widely read dermatology journal in the world. And the article references the National Psoriasis Foundation Resource Center for COVID-19 as a place where we will put updated guidance, because things are changing so rapidly, we won't always wait to go through the lengthy peer review process before we put new information out for our community. All right, so we broke things down into 5 basic categories, and this was based on a lot of input we received from the professionals at the National Psoriasis Foundation, who are in touch, on a daily basis with patients and providers, not only in the United States but all around the world, and had a deep understanding of what the questions are that are on people's minds that people need to know the answer to. So, the first basic question or category that we were trying to address is, what are the effects of having psoriatic disease itself on the likelihood of getting infected with SARS-CoV-2, it's a virus, and outcomes related to COVID-19 illness? And of course, this is because we know that people with psoriatic disease have, fundamentally an inflammatory or autoimmune type condition. And therefore, there's a concern that perhaps that could make them have a different risk of getting infected from the virus or different outcomes from the illness, because we know the the outcomes in COVID-19 are so variable. Many patients will have no symptoms or minimal symptoms, but roughly 15% of people have a more significant illness from COVID-19. So really, our conclusion was that it's not really known having psoriasis and/or psoriatic arthritis alter the risks of having of contracting SARS-CoV-2 or having a worse course of disease. However, the current data, with a few exceptions, indicates that the rates and outcomes are similar to the general population. And so, the initial information we have based on the literature review to date is largely, hopefully, reassuring to people with psoriatic disease, and that it doesn't seem like having psoriasis or psoriatic arthritis meaningfully alters the likelihood of either getting infected with the virus or having a more difficult course of illness if one becomes infected. So we think that's reassuring, but it's an area of the literature that we're monitoring closely as larger and more robust data may emerge. The second recommendation that we put out was that the likelihood of having poor outcomes from COVID, this means like things like getting hospitalized or needing a ventilator or dying from the illness, this is driven primarily by underlying health risk factors, not psoriatic disease or its treatments per se. And as I mentioned earlier, older age, having chronic heart, lung, or kidney disease, or metabolic disorders such as diabetes or obesity seem to be the biggest factors in driving bad outcomes from COVID-19 illness. The second broad category of questions that we wanted to address was what are the effects of psoriasis or psoriatic arthritis treatment on SARS-CoV-2 infection, the likelihood of getting infected, and outcomes related to the illness, COVID-19. And here, of course, many of us in our community are concerned because we know that we use a variety of different approaches to manage psoriatic disease that modulate the immune system. We don't necessarily consider these treatments broadly immunosuppressive for most of the therapies we use, but they are immunomodulatory, and therefore there's a question of whether or not they would make people more prone to these infections or having worse problems with COVID-19 illness. And as many of you know who may be on some of these therapies, biologics, if you will, or methotrexate, or some of our older therapies like cyclosporin, many of these therapies come with warnings for susceptibility to infection. And the virus SARS-CoV-2 is just that. It's a novel coronavirus, and therefore it's unprecedented. We don't have prior experience that we could draw on with certainty to know how the virus will behave with respect to the therapies we use. And after reviewing the literature, over 100 papers out there reporting on the experience of thousands of patients around the world who got sick with SARS-CoV-2, had COVID-19 illness, and either had psoriasis or psoriatic arthritis, or had other diseases that are being treated with similar therapies like TNF inhibitors and methotrexate, diseases like inflammatory bowel disease or rheumatoid arthritis. We're able to learn a lot from this broad community. And our conclusion is that the existing data generally suggests that treatments for psoriasis or psoriatic arthritis do not meaningfully alter the risk of acquiring SARS-CoV-2 infection or having worse COVID-19 outcomes. In fact, some of the data seems to suggest that amongst patients being treated for these inflammatory diseases, that some therapies may be associated with better outcome. For example, people on TNF inhibitors tended to have better outcomes with COVID illness than patients with, say, rheumatic disease or inflammatory bowel disease on other therapies. And as a result of this information, the committee felt quite confident and had strong consensus that if you're not infected with SARS-CoV-2, that we recommend that patients continue their biological oral therapies for psoriasis or psoriatic arthritis in most cases. There may be some individual patient preference situations, and shared decision-making is certainly necessary. So for example, we discussed earlier how there's a wide variety of outcomes related to COVID-19 illness. And so for example, patients who say may be older, may have many underlying health problems, perhaps are at higher risk of contracting the infection because of exposures in their lives, and maybe have more mild underlying disease. Those patients, after discussion with their healthcare providers, may decide that the uncertainty is too worrisome for them, and they might want to pause their therapy. But that's a small percentage of patients. We think for most patients, it's likely best to stay on therapy. And what we've learned so far is that after the first several months of the pandemic, what we see in our clinical practices in the literature is that the patients who have stopped their therapy 3 to 4 months later, they're then trying to see their doctors for flares of their disease. And then patients have to deal with two things: the burden of this pandemic and the changes in our lives that we need to make, and then the burden of flaring psoriatic disease. And so again, that's why it emphasizes that for most patients, we think the right choice is to maintain their psoriatic disease therapies during the pandemic, unless they become acutely infected. The second thing we observed in the literature for other inflammatory diseases, rheumatoid arthritis or inflammatory bowel disease, that those were taking, say, 10 milligrams of steroids a day or more had worse outcomes than patients not taking those levels of chronic steroids. And so therefore, patients who are on chronic systemic steroids, typically for arthritis, psoriatic arthritis, chronic use of systemic steroids should be avoided if possible in the management of psoriatic arthritis. For those who are taking chronic steroids, it's important to discuss with your healthcare provider before altering the dose. But there should be a discussion in place about whether or not it's possible to taper the dosage to the lowest dosage necessary to maintain control of your symptoms. So the second question is coming back to the issues of the impact of the disease's treatments on the infection and illness. Our next recommendation really addresses patients who are newly diagnosed and maybe contemplating going on treatment for psoriatic disease. And here we had strong consensus again that people who are newly diagnosed with psoriasis, psoriatic arthritis, and are not currently receiving treatment should understand that untreated psoriatic disease can lead to serious effects on physical and emotional health. And in the case of psoriatic arthritis, can lead to permanent joint damage and disability. And therefore, we believe, again, for most patients, the right choice will be to go on appropriate medical therapy, manage the psoriatic disease, despite the concerns of the pandemic today. Finally, we really emphasized the importance of shared decision making. We're in a situation now where there's a lot of unknowns, and our knowledge base is expanding, day by day, week by week. And ultimately, we're fortunate in the field of psoriasis and psoriatic arthritis that we have multiple different ways of managing this disease, and patient preference, their individual circumstances, their underlying health issues, and their underlying disease severity is really what drives our decision making. So we encourage you to discuss with your healthcare providers the benefits of your treatment, the proven benefits that you're experiencing, as well as your response to prior therapies. Those who have been on multiple prior therapies are people who we would want to make sure had their disease maintained. We don't want them losing response to treatment. The activity of your skin or joint disease is important to consider. Your underlying risk of having poor COVID-19 outcomes, like we discussed earlier, age, underlying health problems. Your ability as a patient to maintain our preventative measures, washing hands regularly, wearing a mask, practicing physical distancing, staying 6 feet away from others that are not your household members. And of course, a review of the known benefits of treatment accompanied by understanding that there's some degree of uncertainty despite the fact that we have some preliminary information that's quite reassuring so far. And as I indicated before, individual circumstances and patient preferences are very key to our decision making. Okay, and now I'm going to turn it over to Dr. Ritchlin, who's going to discuss the next series of categories.
Joel, thank you for that great presentation. First of all, I want to acknowledge the support of the National Psoriasis Foundation. This group catalyzed formation of this task force and the guidance statements that you're now hearing. And I also want to thank Stacy Bell for providing all of the support for the webinar that we are now engaged in. So I'm going to talk now about category 3. How should medical care be delivered to patients with psoriatic disease to lower their risk of infection with SARS-CoV-2 while still ensuring quality of care? And we've seen during this pandemic the emergence of telemedicine, telehealth as a way to manage patients at times when face-to-face visits are not possible. And so the telemedicine appointments seem to be appropriate for the evaluation of clinically stable and previously started on a psoriatic disease treatment. for follow-up visits and refills for medication, for new patients without timely access, and for those diagnosed with COVID-19 who have a significant flare. I should emphasize that through this mechanism, our offices, and I know Dr. Gelfand and others, have been able to communicate with patients who've not been able to leave their home and to be able to counsel them on how to take their medications and continue the medications along with the guidance statements which are being discussed now. It's vitally important because many patients not having access to information were stopping their medications and putting themselves at increased risk for flare of their disease. If telemedicine becomes inadequate to manage disease progress, new or evolving symptoms, signs of skin and joint disease, then an in-person visit should occur. How should medical care be delivered to patients with psoriatic disease to lower their risk of infection with SARS-CoV-2 while still ensuring quality of care? If pandemic conditions allow and the clinic is open, consider an inpatient visit for if you're at risk for melanoma and non-melanoma skin cancer should be seen in person with a frequency consistent with standards of care. A new patient appointment establishing care. Unstable psoriatic disease or flares. Thorough skin and or joint examination. And full examination for rheumatology patients. Having said this, there are ways to view the joints, particularly of the upper extremities, using telemedicine. And we have used this strategy for those patients who simply cannot come for an in-person visit, and it's proven to be very effective. Certainly, viewing the lower extremities, though, is a lot more challenging and problematic. Be aware guidelines are available regarding how to optimize safety of office phototherapy in the setting of a pandemic. Category 4. What should patients with psoriatic disease do to protect themselves from becoming infected with SARS-CoV-2? First of all, follow preventative measures identified by the CDC. These include good hand hygiene, physical distancing, wear a face mask covering the nose and mouth when in public spaces. Exception to this, of course, are children aged 2 and under. One should also follow measures to prevent infection with COVID-19 in the workplace. If no guidelines, discuss with your healthcare provider if accommodations are needed. We have had several patients come to us with concerns that their workplace was not following the CDC guidelines. And in those cases, we have intervened to help our patient establish a workplace that is safe. What about school? This is a major issue that's facing the country at the current time, as you well know. Specifically, what should patients with psoriatic disease do to protect themselves from becoming infected with SARS-CoV-2? Well, first of all, follow measures to prevent infection at school. Maintain 6 feet physical distancing. Consistently wear a face mask for youth over the age of 2, covering the nose and mouth, and wash hands frequently. If the school is unable to ensure preventative measures, or if the child is not able to adhere to such measures, discuss with caregivers and healthcare providers to develop a learning plan that includes the safety of the child. Another really hot topic at the current time is vaccines. So, what should patients with psoriatic disease do to protect themselves from becoming infected with SARS-CoV-2? Patients with psoriatic disease should receive the seasonal, inactivated, or dead influenza vaccine when available, and these are now generally available at physicians' offices and in pharmacies. It's important to underscore that the influenza vaccine will not protect against SARS-CoV-2, but it lowers the risk of infection from seasonal influenza. Also, if taking systemic medications, discuss the timing of influenza vaccination with your healthcare provider to optimize the response to influenza vaccine. And this relates largely to patients who are taking methotrexate for either psoriasis or psoriatic arthritis. Category 5. What should patients with psoriatic disease do if they become infected with SARS-CoV-2 COVID-19? First of all, monitor symptoms and discuss management of their treatments with their healthcare providers. Symptoms to monitor at home and seek immediate care if the following warning signs develop: trouble breathing, persistent chest pain or pressure, confusion, inability to stay awake, or bluish discoloration of the lips or face. It should be prescribed and adhered to evidence-based COVID-19 therapies, and evidence-based therapies include Supported care if disease is mild. For hospitalized patients, remdesivir or dexamethasone, which are systemic steroids. These should also include in this care the consultation with rheumatologists, dermatologists, and/or infectious disease specialists as medically necessary. So, treatment discussion. What should patients with psoriatic disease do if they become infected with SARS-CoV-2? Systemic steroids should be used based on demonstrated effectiveness for treating COVID-19 and is not contraindicated. Treating COVID-19 is certainly the priority. Hydroxychloroquine or chloroquine are not recommended for the prevention or treatment of COVID-19 in patients with psoriatic disease outside of a clinical trial. Cases of psoriasis flare have been reported in patients on anti-malarial medications, but the clinical significance is not well understood. Resuming psoriasis and/or psoriatic arthritis treatments held during SARS-CoV-2 should be discussed with your healthcare provider on a case-by-case basis. What should patients with psoriatic disease do if they become infected with SARS-CoV-2? Infections with SARS-CoV-2 may result in a flare of psoriasis. The clinical significance of the cause is not known. If infected, follow CDC guidance on home isolation and follow up with your healthcare provider, and this is a case-by-case approach. And lastly, quarantine for 14 days if in contact with someone who is infected. Discuss treatment of psoriasis with your healthcare provider. I am now going to turn the summary over to Joel.
Okay, thanks, Chris. So in summary, the National Psoriasis Foundation COVID-19 Task Force is actively monitoring developments and will issue new guidance as indicated based on advances in our scientific knowledge of COVID-19 and how it's related to psoriatic disease. And certainly this is really where you, our community, come in so important by communicating with the NPF, your questions and concerns about dealing with the pandemic. That allows the committee to be certain that we're focusing on issues that matter most to you all. Of course, we want to emphasize again, the basic CDC public health prevention guidelines. Wearing a mask when out in public, certainly wearing a mask when indoors outside of your own home, washing hands regularly, and maintaining physical distance of 6 feet from other individuals who are not part of your household unit. You should understand your underlying risks for having a bad outcome from COVID-19 illness. As we mentioned again before, age, underlying comorbidities are what drives the risk of bad outcomes. And therefore, individuals in these high-risk groups need to be the most cautious about protecting themselves from vulnerable situations. It's also important to discuss with your healthcare providers the use of vaccines. Of course, the killed seasonal influenza vaccine shot is recommended for most patients. And the important thing here is that if one was to have both influenza and SARS-CoV-2 at the same time, that could be a very difficult infection to undergo. And keep in touch with our COVID-19 Resource Center on the National Psoriasis Foundation's website. Keep an eye out for our updates from our task force. And this is what it looks like. Here's the link for it that you can go to online. There's a registry where researchers can report cases, guidance about telemedicine, our podcasts, of course, and other resources there from the National Psoriasis Foundation. And I'm going to pause there, and I think we should be ready for questions, Bev.
Great. Well, thank you, Dr. Gelfand and Dr. Ritchlin, for your presentation. It's very informative. So it's now time for our Q&A portion of this webcast. If you have any additional questions based on what you've just heard, please submit them through the questions panel on your attendee interface. We'll attempt to answer as many questions as possible in the remaining time. So a question for Dr. Gelfand to start. I have pustular psoriasis and want to know how this affects me during COVID-19.
This is a great question. So, pustular psoriasis is a rarer variant of psoriatic disease. There are different forms of it, generalized pustular psoriasis, and then more localized palmoplantar pustulosis, if you will. And there hasn't been much in the literature yet about the impact of this pandemic on patients with pustular psoriasis. But I think our overall recommendations that I brought out, discussed earlier, I think still apply to people with pustular psoriasis, because we know that's one of the harder variants of psoriatic disease to manage, and therefore trying to maintain control of that disease is especially important.
And for Dr. Ritchlin, should patients living with psoriasis use a N95 mask or a cloth mask? What's the best recommendation for?
Well, there's a lot of different information out there regarding accurate response to this question. I will take a middle ground in terms of what we do in the hospital, and that is when seeing patients and not engaged in actively doing procedures that involve respiratory contact, such as intubation or other areas around the nose and mouth, we use the masks that are provided by the hospital, which are not N95. Certainly, N95 masks are quite excellent at preventing the spread of the virus when you're having a lot of contact with droplets, but they're not required. I would say a cloth mask really depends on how it's constructed, and just having a cloth in front of you may not provide adequate protection against the virus. So again, using the masks that are commonly used in the hospital that are not expensive, and you've seen them out there, they're either blue or yellow, should be adequate if worn covering the nose and mouth. N95 masks are not required, but obviously can still do the job.
Yeah, and I would agree with that. I think our experience at University of Pennsylvania dealing with a surge of coronavirus patients is that we really didn't see infections occurring between patients and staff, or staff and patients, when just using a regular 3-ply surgical mask. These are widely available on the internet or regular pharmacies around the country. And that's, I think, reassuring patients that does add some protection. The N95 to work properly really needs to be fit properly. They're uncomfortable, they're difficult to breathe in. And in most circumstances, unless you're in a situation with exposure for a prolonged period of time, intubating patients with the virus, which of course most patients should not be doing, then a 3-ply mask is sufficient. In some circumstances, you may want to consider additional protections like a face shield or eye protection. So if you're in a scenario where you're going to be encountering crowds, for example, the way that the virus is transmitted is if someone coughs and sneezes and those droplets land on your nose, your mouth, or your eyes, that's how the infection is transmitted. And so that's why a mask that covers your nose and mouth could be so effective, and eye protection could be useful also if you're going to be in a situation where you're going to be exposed to a crowd of people.
Question for you both. Is there any evidence that it is riskier for a person with psoriasis or psoriatic arthritis to participate in a COVID-19 trial?
So the answer to that question is we don't know. I think that when you're testing vaccines, and even inactivated vaccines, which we're talking about here, there can be untoward events that are not expected. And so I would say that in patients who are taking medications for their psoriasis or psoriatic arthritis, whether that be biologic medications or systemic medications taken orally, such as methotrexate, I would personally advise my patients not to be engaged in an early clinical trial of vaccines. I will let Joel talk about patients with mild psoriasis who are not in any medications.
Yeah, so I think that when these studies are being done, especially the larger phase 3 trials that are used by the FDA and other regulatory bodies to ultimately decide on the safety and efficacy of an intervention, in this case a vaccine, that those tend to be done in much larger populations of patients, tens of thousands of individuals in the case of a vaccine. And those studies will have criteria, inclusion and exclusion criteria. So from my perspective, actually, I think that if the study was designed and is overseen by a data safety monitoring board and institutional review boards and things of that nature who are designed to protect human subjects, the inclusion and exclusion criteria allow for people with psoriasis in the study, or allow for them to be on some of these medications that we use for psoriatic disease. I personally think it's probably okay. Of course, it's always best to discuss with your own provider in these circumstances, but the studies are carefully designed with inclusion and exclusion criteria to help optimize the safety of the human subjects in the clinical trial. And so I would say having psoriatic disease or being on treatment is not itself an absolute contraindication to pursuing being a part of the research going on. The other thing I was mentioning for the audience that they should be aware of is that several therapies used for psoriatic disease, including TNF inhibitors, like a drug like adalimumab, for example, and IL-17 inhibitors, drugs like secukinumab or ixekizumab. These are being studied in patients who don't have psoriasis or psoriatic arthritis, but in patients who have severe COVID illness, to see if it could reduce the overactive immune response some patients have to this virus that ultimately causes a lot of the morbidity and mortality from the infection. And so we may learn a lot in the ensuing months about whether the therapies we commonly use for psoriatic disease have a role to play in treating patients who have severe COVID illness.
That's interesting. And along the line of vaccines, will the upcoming vaccine be based on a live virus or synthetic?
Yeah, so all the platforms currently are not live viruses. So that they'll all be killed viruses, and therefore, in theory, would not be contraindicated in patients, currently taking immunomodulatory therapy for psoriasis. Although, of course, we'll have to learn more as these go through the approval process.
Agreed.
What's your thought on this, Chris? Yeah.
Yeah, I agree.
And for Dr. Ritchlin, is taking prednisone contradicted in the case of COVID?
Well, I think this was discussed in the guidance statements, and that is certainly in the case of psoriatic arthritis, there are patients who are taking low doses of prednisone. We try and avoid prednisone in the treatment of psoriatic arthritis because we know that tapering the medication can trigger a flare of psoriasis. Prednisone itself or corticosteroids have their own side effects, especially when taken chronically. So what we tell the patients, and this is outlined in the guidance statement, is if they are going to be on prednisone, that they should be on the lowest dose required to maintain their disease. And in patients right now who come in with psoriatic arthritis and a flare, we really do try and minimize the use of this medication, again, at the lowest dose. Now, this may seem counterintuitive when it's known, as mentioned again in the guidance statements, that dexamethasone and other corticosteroids are used now to treat the severe COVID-19 patients who are in the ICU, and there's evidence now to support that. But that's a different situation where you're using the corticosteroids to treat a specific indication of the virus versus patients taking the drug for the treatment of their underlying psoriatic disease.
I just want to emphasize some of Chris's points, which is that, if you're on chronic steroids, prednisone for psoriatic disease, psoriatic arthritis, of course, you want to talk to your healthcare provider about the ability to sort of taper to the lowest dose, as Chris mentioned. But if you get acutely infected with the virus, you certainly want to talk to your healthcare team about what to do with your chronic steroids you're on. Usually, we won't stop them acutely in the setting of an infection, because that could result in a lot of negative outcomes for patients. Steroids are one of the things we don't stop abruptly, whereas a lot of our other therapies, methotrexate or biologics, we often could delay them or hold them in the setting of an acute infection. And then the reason why they put out these guidelines about reminding the medical community that systemic steroids can be used to treat COVID illness in people with psoriatic disease is because many clinicians learn in medical school that steroids can aggravate psoriasis, cause a flare when withdrawn, and may be fearful of using these potentially life-saving therapies in patients who have severe COVID illness if they have underlying psoriasis. And we want to make very clear to the medical community that in that circumstance, the priority is getting the patient through the acute illness of COVID-19, and then we in dermatology and rheumatology have many options to get the disease back into control if there's a flare of psoriatic disease related to either withdrawal of steroids or the underlying illness of COVID-19.
For both of you, this is from a parent. We're thinking of switching our 9-year-old from a TNF inhibitor to an IL-17. Is there a reason to wait until the COVID-19 threat dies down?
Yeah, so I think what we would say is, based on the guidance that we've put out, recognizing the uncertainty we have there, but also the emerging data we have, it's been largely reassuring. We think that in most patients, and certainly a 9-year-old is in the category of someone who presumably would be lower risk for bad COVID outcomes, especially if they don't have any other major health problems like diabetes or severe obesity or something like that, that they're relatively low risk for having poor outcomes from COVID-19. And therefore, the treatment decisions should really be derived from what's in the best interest of managing their psoriatic disease. So, if the patient's doing well on their TNF inhibitor, in most cases, we would say stay on it. If they're not doing well and there's a need to change therapy, an IL-17 may be perfectly reasonable. What do you think, Chris?
I agree, Joe. I think another way of asking this question is the following. Is there evidence that taking or being placed on an anti-TNF agent is going to lead you to have higher susceptibility or poorer outcomes in relation to COVID-19 than an anti-TNF or vice versa? And the answer is we could not find evidence for that. And we really searched hard, as Joel mentioned. We reviewed over 1,000 articles, and there are studies that have been performed in the United States, Northern Italy, and China, where large cohorts of patients that have COVID-19 and were on these medications were analyzed, and there's just no evidence that any of these agents discussed for this patient would pose a higher risk for development of the disease or a more serious outcome.
And to some extent, the TNF inhibitors have some hints that they actually may result in a favorable outcome from COVID-19 illness. And despite some of the label warnings they have, a viral infection is a very different thing than, say, tuberculosis or bacterial infection. It's a different immune pathway, and therefore TNF may not be as concerning for a viral infection like SARS-CoV-2 based on our current understanding of the biology.
But Joel, I think that's absolutely true. But I know that you published a recent paper, and we've discussed at some length the fact that when you analyze the data from phase 3 trials in psoriasis and psoriatic arthritis, and certainly other immune-mediated diseases, the incidence of viral infections and the type of viral infections are not really very well documented. So it's really hard to gain a baseline of what it's like for patients with psoriasis and psoriatic arthritis in terms of viral infections, both without and with biologic or systemic agents.
Right. Yeah, I think that's absolutely right. And part of it is because, respiratory infections generally are pretty trivial. They're usually mild and self-resolve without any treatment, and therefore haven't drawn a lot of scrutiny. I think the best we could say is from the analysis that we've published, at all the data from the pivotal trials, interestingly, the patients on TNF inhibitors for psoriasis, we just focus on psoriasis in these studies, these trials, had no difference in the rate of respiratory tract infections during a placebo-controlled period. Pretty reassuring for that class of medications.
Agreed.
We have a few healthcare providers who are listening tonight. They would like to know, do you have any recommendations for either nurses or pharmacists on what can they do if they're encountering people who may be positive and they're not wearing a mask or they're in the hospital?
Talk about what my practice at Penn is, and maybe Chris could talk about what his practice at Rochester is. And so our basic practice is, one is we try to screen patients in advance, and those who have known COVID exposures or are symptomatic are patients we don't want to see in the office. So we try and treat them via telemedicine and make sure they have the appropriate testing to see if they have the virus. Assuming patients are asymptomatic and have no recent exposure to others with the virus, the risk is rather low in a lot of communities. It depends on where you are, that someone has asymptomatic infection. And what we do at my practice at Penn is I wear a 3-ply surgical mask. I wear the same mask all day. I wear a plastic face shield. And I wear scrubs, and I sanitize my hands regularly throughout visits with patients, and we sanitize all the high-touch surfaces frequently throughout the day. We also try and limit our face-to-face time in a room with a patient to less than 15 minutes. And so that way, following these recommendations, we think the risk of transmitting the virus is extremely low. We haven't really seen it occur in our setting at Penn since we've been implementing this approach during the pandemic. Chris, what's your approach been?
I think our approaches are very similar, and I think they're similar across healthcare facilities across the country. In addition to what you've just described, Joel, which is exactly what we do in our office, 3-ply masks, as well as limiting face-to-face contact. And also at the entry to our office, there's someone at a table outside who has the patient answer a few questions, who's coming into the office, and then takes their temperature and has them clean their hands with hand sanitizer. These kinds of precautions, plus in the hospital, when people are entering entering the University of Rochester, and I'm sure Penn as well, they undergo the same kind of process before they can get into the door. So
Yes.
with these type of approaches, the spread of the virus has been really very strongly limited. And we obviously had great concerns at the beginning of the pandemic when our neighbors in New York City were undergoing such a rapid rate of spread that we instituted rapidly these kinds of restrictions and changes in the way we cared for our patients that I think had a major impact at limiting the spread of this virus.
Yeah, and I think the one thing we haven't mentioned, and is in the guidance that people can read about, or a table in a publication around management of phototherapy, it talks a lot about these protective measures. The other thing is really had a patient come alone to the visit, unless they're a child or not an adult. Because again, we're trying to sort of depopulate the office and the campus, and so the days of being crammed into an exam room with patient, their spouse, their children, their friend, that's really not something we could do during the current pandemic. Ideally, the patient comes alone. If they have a spouse or a friend who's with them, they need to wait outside of the medical center.
Agreed.
If the healthcare worker is on the front lines with COVID patients in the hospital, say ICU, what do they do?
Our experience at Penn is that the rate of our frontline workers getting infected when they're wearing their PPE has been extremely low. And I have many patients who have bad psoriatic disease who are frontline workers on multiple immunomodulatory therapies. And we explain what the issues are, and it's a personal decision for the patient in that setting. I would say for many of my patients, the call to duty outweighs their concern about the uncertainty. In general, people have elected to maintain their professional frontline responsibilities.
Well, I totally agree with Joel. I think that many of our colleagues, particularly those who were in extremely high COVID environments, such as in New York City and now with our colleagues in the South and the West, that many, at least physicians that I know of, who have young children at home would actually quarantine themselves while
Yeah.
they were working on these more critical wards for the time that they were there and for 14 days after. Whether that's necessary or not, I don't know, but I think if I had young children, that's probably something I would do as well.
Yeah, it's certainly a challenge for those who have vulnerable people at home, older parents, very young children. I was teaching a class to fellows in cardiology and pediatrics and oncology when the pandemic broke out, and several of the students in my class, had new babies born, and they were on the front lines in the ICUs, and they couldn't even hold their newborn children. And so I think it's really incumbent upon all of us being this together to lower the prevalence of this disease as much as possible, lower the burden on the frontline healthcare workers, because ultimately they're the ones who take the biggest brunt of a pandemic when it spins out of control.
Okay, well, thank you both very much for taking time to answer our many questions that we've received. Do you have any final words you want to say?
Well, it's my pleasure to be here with you all tonight. I hope this was helpful for the audience, and we hope people will visit the NPF COVID-19 Resource Center regularly and utilize the guidance we're putting out, as well as communicate with the NPF what their questions and concerns are, so we can be sure we're responsive to the community.
Yeah, I think it's also important to underscore that we are continuing our efforts to monitor the literature. Should, and they certainly will, changes occur and advances over the course of the next coming weeks and months. And as the situations change, we will make sure that this information is posted on the website and put into our publication in another version of our guidance statements.
Again, thank you both very much for today's webinar.
Thank you.
Good night.
In addition to today's webinar, podcasts are also available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like more information about the COVID-19 guidance statements, you can listen to podcast number 91, also by Dr. Gelfand and Dr. Ritchlin, or if you need help preparing for telehealth visits, catch episode 83 with Dr. George Hahn. You can also hear more information about participating in a registry, So Protect Me, which is collecting data during the COVID-19 pandemic, and that's episode 85. Contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone, email, or as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others who have psoriatic disease through our one-to-one program, which offers trained volunteers who have a connection to the disease. Reach out at education@psoriasis.org or call 800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Finally, you can access our webcast archive on our new Watch and Listen page. This concludes our presentation for today. Thank you for attending.